The topic today is really on, something that we've certainly been hearing more about, but is still, I see it everywhere now. It seems that way. And David has been a champion for this with us here and educating us. And again, on transthyretin, cardiac amyloid, underdiagnosed, underrecognized, and undertreated by Dr. David Bewick. So you're open to start.
Okay, perfect. Thanks, Jeff. So yeah, this is to me, it's a fascinating disorder, and I've learned a great deal in the last couple of years compared to 10 years ago, which I thought was really a zebra. Well, we're now recognizing that this is not a zebra, and certainly the timing is right for this type of talk because it's being increasingly recognized and increasingly diagnosed, unlike the title. Now, let's see, I have to get rid of that. Now, how do I move that forward? There we go. So the objectives here to understand the clinical importance of TTR, the cardiologists, cardiac surgeons, allied healthcare, recognize the red flags. How do you diagnose transthyretin amyloid? And what is the contemporary management of TTR? And really, this is a major change compared to years ago where we really had no treatment. Now we have very effective treatments for at least stabilizing the disease. Well, the next 15, 20 minutes, we're going to discuss these objectives. Why is it important? Number one, for cardiologists, cardiac surgeons, it's a relatively common cause of heart failure with a preserved ejection fraction and low flow, low gradient aortic stenosis. And we now have therapies which can actually halt the progression of disease. So this has been a major milestone, in my opinion, in managing these types of patients. And that's why it's incumbent on the clinicians to diagnose this, because we do have therapies. And really, this is what I call a wolf in sheep's clothing, because each one of these abnormalities, as you see on this diagram, amyloid can present. So it's a systemic disorder. So it's a cardiologist or cardiac surgeon seeing a patient with a heart disorder, but it's an underlying systemic disease. And as you can see, you can have a myriad of system involvement from biceps rupture. You can very commonly get bilateral carpal tunnel syndrome. In fact, if you see someone who has a bilateral carpal tunnel syndrome release 5 or 10 years ago, that is a clue to amyloid. Spinal stenosis is very common because the protein, the amyloid protein, has a predilection for certain tissues. One is the carpal tunnel. The other is the biceps, so-called Popeye sign, if you rupture your biceps. And the third, it has a predilection for the ligamentum flavulosum flavum, and that's why spinal stenosis is fairly common in this disorder. And certainly, where we see in the cardiac field is syncope, where you can have severe orthostatic hypotension. I saw a patient a few months ago who's losing weight and ended up with a pacemaker. And she looked like she had cancer and turned out to have gastric amyloid. And certainly bruising is very common because of these tissues, subcutaneous tissue is more prone to bleeding. So you can have raccoon sign, bruises around the eyes, or multiple bruises. So this is why it's important for us to recognize disorder and recognize it is a systemic disorder. So the hallmark from a cardiologist's perspective is undifferentiated LVH. So if you see LVH on an echo, I think we all recognize. So this could be, the patients could present to the cardiac surgeons, could present to the heart failure specialist, cardiologists with hypertension, or even the EP people with atrial fibrillation. If an echo comes back as showing moderate LVH, think of a systemic disorder such as amyloid. This patient has amyloid. I'd like to just, over the next 5 minutes, talk about a case presentation. So this patient was seen by many cardiologists, interventional cardiologists, and several cardiac surgeons, and was referred for evaluation of shortness of breath. So he lived in the rural area, was a white farmer, active, independent, saw a cardiologist with shortness of breath, and this is a typical scenario. And then we talk what I call the journey. He showed LVH on his echo 2013, 2014, poor exercise capacity. CTA showed heavily calcified coronaries. Cath showed occluded LAD, critical lesion is OM. Went on to have a PCI, which is classical here, and had no improvement in his shortness of breath. That's an intervention's done, but no improvement. Continues to have functional class 3 dyspnea. We're now 5 years later, and now an echo shows moderate aortic stenosis. Again, a mean gradient of 28, valve area 0.9, significant LVH, so out of proportion to his aortic stenosis, and not infrequently, because of diastolic dysfunction, he had pulmonary hypertension. And the patient, who is an active farmer, says, I can't do anything. Family and patient are very frustrated. This is a typical journey. Most of these patients see 3 to 4 specialists, and it takes on average 5 years to diagnose. Here's his echo. Now you can see several abnormalities here. You see LVH, very impressive basal septal hypertrophy. You see the distal apex is akinetic, so this is in keeping with coronary artery disease. One gets a sense there may be even RVH. You see thickened atrial septum. The mitral valve and tricuspid valve are somewhat thickened, but not terribly thickened. Here's the aortic valve. You can see it looks moderately stenotic. You see a mean gradient of 33. Look at the inflow, that restrictive pattern, high velocity, E velocity, and a rapid decel time, all typical of very severe diastolic dysfunction. And it does look like moderately severe aortic stenosis, maybe even bordering on severe. It's seen by cardiology again, 2019, has another cath, and now you can see he's got a patent stent. He's got distal RCA, circumflex disease. Look at his EDP, 30, another classical finding, high filling pressures, but his mean gradient is only 30. So even the surgeons would say, does this patient really need a TAVI? He has another PCI, no benefit. So he said, well, and also has a CAT scan done for pre-TAVI, severe spinal stenosis with prominent LVH. Those are 2 red flags right there. So the advocate for a TAVI, as nothing else has worked because he's now functional class 3, give the benefit of the doubt. And there's nothing wrong with attempting that in this setting, particularly given his disabling symptoms. So he has a TAVI. 1 week post-TAVI, I get to meet him when he comes back to he's admitted with heart failure, discharged from CCU, back to the emergency room 3 weeks later. You see that JVP going to the angle of his jaw. That's typical of this disorder. He's now short of breath coming into the hospital. He's got a brief systolic murmur. He has no evidence of aortic regurgitation. His x-ray shows congestive heart failure. Once again, the echo shows impressive LVH, normal EF, and the aortic valve prosthesis is functioning properly. So the management here is, as you can see, was seen by many people over 5, 6, 7 years, no improvement with interventions, be it for his coronary arteries or his valve. So the key learning point here is aortic stenosis by echo and cath was not severe, but he was incapacitated with shortness of breath and had documented clinically and radiographic heart failure. And look at his biomarkers, another red marker, another red flag. These patients typically, because of the infiltrative process, have elevated markers. So his BNP and troponin are high. This is a typical pattern for echo where you get sparing of the apex. So you have apical sparing. Just go back to that. Where you get what they call a cherry cherry top, it's called, or I like just calling it apical sparing, and bullseye is another word, where you get increased contractility of the apex, and the process, the infiltrative process, affects predominantly the basal constrictors initially. That's why you get convection system disease, because it affects around the AV node. And you have this typical pattern. It's not 100%, but it's very specific. So if you look for this, if you're wondering about an infiltrative cardiomyopathy. So whenever you get a diagnosis of amyloid, it is mandatory you follow 2 routes. One is you have to exclude myeloma. So it's you do the try, and we actually have a stamp up here in the heart function clinic where you get serum-free light chains, a protein electrophoresis, and a urine protein electrophoresis or Benz-Jones. So it's mandatory you rule out myeloma. Went too fast. Which is negative. There we go. We're just having a little problem with this. Yeah, so the next one was technetium pyrophosphate scan. So this has changed the management of this disorder because we can now diagnose it without having to do a biopsy. If it's strongly positive, which is characteristic for this disorder, and the sensitivity, by the way, and specificity is 95%. So if you have TTR, the sensitivity of a technetium pyrophosphate scan is 95%. For some reason, those jump forward. There we go. So he's placed on furosemide and spironolactone. He remained in hospital. He was transferred to a nursing home, but while waiting, he died. So this man went through many, many investigations. And in retrospect, now that we recognize this disorder, if we had done a PYP scan when he came in with his aortic stenosis, we may have taken a different track. Maybe not, but we might have. And that's what we're currently going to be doing a study on this type of patients. So the teaching points here, there are several clues when one steps back. Each one in itself is not diagnostic, but however, there's several clues here. Severe spinal stenosis, disabling symptoms with only modest coronary disease and aortic stenosis. Cardiac biomarkers were significantly elevated. His X-ray showed heart failure despite a normal EF and no improvement after interventions. So all of these were clues that maybe this patient had an infiltrative cardiomyopathy. So cardiac amyloid is characterized by diffuse involvement with LVH because of the protein. The atrium are infiltrated, which causes atrial fibrillation. It affects the basal constrictors, so the AV node. So not infrequently, they have a left bundle branch on their ECG. And it also affects the coronary arteries, where you can get microvascular ischemia. So for their interventionalists, if you have someone who has classical angina, but coronaries are not that impressive, and they have elevated cardiac markers, think of an infiltrative disorder. So amyloid is a protein that becomes misfolded, and you get these fibrils that are deposited in various organs. Now we're talking about transthyretin today. So what does that mean? It used to be called prealbumin. So it's synthesized in the liver. It's a protein that transports thyroxine and retinol. So it's a homotetramer, so it's 4 proteins that are combined, and that's stable. An unstable tetramer is where they get misfolded and unfolded and get deposited typically in the neurological system or the heart. So 4 identical monomers, and there's many mutations that can occur. We're now recognizing over 130 in this monomer. It used to be thought to be rare, but now we're recognizing it's increasingly common. And there's 2 types of amyloid, transthyretin amyloid. The first is hereditary. So the cardiologists, cardiac surgeons won't see this type of patient. Typically, they present with a peripheral neuropathy. So hereditary, it can affect the heart, but more likely the neurological system. The wild type is the type we see. So you have a spontaneous mutation, and this misfolded protein gets deposited, and typically in organs such as the heart, but as we've talked about, the wolf in sheep's clothing, it can be multiple systems. So 2 types. Why is it important? Because if you diagnose TTR, all these patients should have a genetic sequencing done, and we've arranged that here at the hospital, where we send it to Blueprint Genetics in Finland, and they can differentiate hereditary. So if you have an inherited TTR protein, they will pick it up on a genetic screen. Why is that important? Because the family members could have it. And you can have older patients, 60, 65, 70, 75, who can have hereditary, so then you check the children, much like we do with a hypertrophic cardiomyopathy. Presentation we talked about, typically it's heart failure with a preserved ejection fraction, right side heart failure. If you see someone with a hypertrophic cardiomyopathy or diagnose that in someone who's 65, 70, think of amyloid. It's unusual to develop a hypertrophic cardiomyopathy in an older patient. We've talked about low flow, low gradient aortic stenosis, atrial fibrillation, conduction abnormalities, and angina with normal coronaries. The characteristic non-cardiac features are severe orthostatic hypotension and a peripheral neuropathy. If you see someone with heart failure and has nephrosis, nephrotic syndrome, think of an infiltrative disorder. Sometimes patients, the protein gets deposited in their tongue, so they can't taste food, and they have a large tongue. Bilateral carpal tunnel syndrome is classical for a number of these patients, and we've talked about spinal stenosis. These fibrils have, as mentioned, a predilection for certain tissues. One is the hands, and the other, this is called Popeye song or a sign, where you have if you have a ruptured biceps in an older patient that's spontaneous, think of amyloid. So the red flags we've talked about, orthostatic, is you develop low blood pressure on someone who's on multiple blood pressure medications. In other words, they develop hypotension on a background of chronic hypertension, heart failure with preserved ejection fraction. We talked about spinal stenosis. Classically, these patients are exquisitely sensitive to beta blockers. In fact, I stop beta blockers, and a lot of them will feel a lot better. So beta blockers, calcium channel blockers, ACE inhibitors, these patients are exquisitely sensitive to. We've talked about neuropathy and right side heart failure and bilateral carpal tunnel. What has revolutionized the diagnosis is the technetium pyrophosphate scan. So ATTR on the left, you can see where you see the heart. It's a dark uptake. So that's a positive scan. And someone who had amyloid due to myeloma light chain disease has a negative scan. However, the caveat is some patients who have amyloid due to myeloma light chain disease can have uptake in the heart. So it is mandatory. If you have a positive scan, you always do screening for myeloma. So technetium pyrophosphate scan is very helpful in diagnosing this. That brings us up to subtyping. So what you might not be familiar with some of these terms, but all patients who have amyloid have a positive Congo red stain. It must be sent off for mass spectrometry. It's either sent to the Mayo Clinic or Toronto. So I've been taking patients, if I have amyloid, I ask the lab to make sure and they do it now automatically, it's sent off for spectrometry to isolate what type of amyloid is it. Is it AL, TTR, or other? So if you get a positive Congo red stain, you can't stop there. You have to send it off for spectrometry, mass spectrometry. Now, how do you manage these types of patients with low flow, low gradient AS? And what if they do have TTR? And we're going to find this out with the study we're going to be doing. We will pick up some of these patients. Here's one study from Jack, who had positive scan. They found in patients who had a TAVI up to 14%. Another study from Europe, 16% undergoing TAVI have occult TTR by looking at a positive scan. So this is where our trial we're going to be doing is going to look specifically at that. And then what do you do with these types of patients? So the diagnosis requires a constellation of clinical lab and imaging findings. We've talked about LVH, undifferentiated LVH. We've talked about it's mandatory if you have a positive PYP, you automatically screen, do that triad, serum-free light chains, protein, electrophoresis of the serum, and urine. And we've talked about different types of imaging modalities. I didn't talk about CMR, but it's also very helpful in diagnosing an infiltrative cardiomyopathy. But really, the history and physical are important. Now, in terms of treatment, we've talked about two types of amyloid. One is the plasma cell, one is the liver. We're focusing today on the liver, transthyretin. So we now have disease-modifying therapies. So we can either suppress the synthesis, so we call them gene silencers, patisiran, inotersen, and they've been approved for the neurological symptoms, peripheral neuropathy. What we've been approved, and we're using it now, is tafamidis, which is a TTR stabilizer. So it prevents dissolution of the tetramer into the monofibrils. So this is how tafamidis works. It stabilizes the tetramer. It's not 100%, it's probably around 50, 55%. But at least you prevent the dissolution or disassociation of these fibrils so they don't get ongoing deposition in the heart and various systems. So we're now using tafamidis. It's 80 milligrams a day. So the approach to cardiac amyloid starts with clinical suspicion. Your ECG is helpful. If you have LVH and low voltage on an ECG, that's a red flag. You then go on to an echo. I like a cardiac MRI in this setting if possible. There's two types of amyloid, serum-free light chain deposition disease from plasma cell dyscrasia, or we've talked about the TTR and looking at a pyrophosphate scan. If you get a positive technetium scan, then you send off for a genetic analysis to determine is it wild type or hereditary. If you get elevated light chains, you get hematology involved, and then generally we'll do a bone marrow biopsy. So this is the algorithm one approaches. Contemporary imaging is vital to diagnosis. We've talked about echo, MRI, and PYP. And finally, the last two slides, what if you do diagnose aortic stenosis and you perform a PYP and it's positive? What do? This is taken out of Jack. It's a nice algorithm looking at it. And finally, if you have, and you can get these, I can give you the reference for this. What if you have symptomatic aortic stenosis and you have amyloid? How do you manage these patients? And this is one algorithm. I think we have to sit back and decide, should this patient be referred for a TAVI, it's a SAVR, surgical aortic valve replacement? Should we start a stabilizer such as tafamidis, or do we discuss about medical therapy? So in summary, it's a complex vexing condition, requires a high degree of suspicion. The clinical picture can be a complex interplay of multiple organ systems with confusing symptoms. You need to approach this with a physical, biochemical imaging, and tissue biopsy, genetic analysis, and treatments directed to the type of amyloid, be it AL or TTR. But the future is promising. We're going to be having many more agents coming out. So it's imperative to make an early diagnosis, because by the time that last patient, he really was end stage. He had that protein deposition was going on for probably 5, 6, 7 years. And once you get a huge burden of protein deposition in your organs, then you've probably missed the boat, and then you have to talk about conservative or palliative therapy. Thank you very much.
Thank you, David. This is great. And I'll open to questions. If they can be posted on the chat box, would be great. I'll ask the first question. Do you think that when patients make it to us from an intervention point of view, it's actually we're too late in terms of starting therapy such as tafamidis, as you suggested? You know, is there a point where we are too late, as you suggested, in this poor man?
Yeah. So by the time you do see them, it's probably well-established disease. So that's why it's important we're doing this study, because I'd like to start screening earlier. But I think the trend is changing. Most people now most cardiologists, internists are at least recognizing that this is a potential disorder. And so are now, and with the PYP scan, it's a fairly simple study to order. It's basically a bone scan. That has really revolutionized the ability to at least diagnose it. And then when you diagnose it and people are thinking about it, well, then hopefully we'll be able to diagnose this more earlier, so you don't get these patients who come to you, as this patient had really a very advanced disease and was seen by many people. But I think if that patient presented now, I suspect there would be a different approach, and we likely would diagnose it much earlier. And I'm too at fault. 10 years ago, I never saw amyloid. Now I seem to see it every three months now. So I think with the early diagnosis and a heightened awareness, it's like SCAD. We never thought, we used to call it coronary spasm. Well, now we know there's SCAD, so we never see coronary spasm anymore. I know Dave Marr's on this call, so I'm sure he diagnosed lots of people with coronary spasm. But now that we know about young ladies presenting with acute coronary syndrome, we look very carefully for SCAD. But I think it's just a way of approaching a disease too.
I wonder if you would comment on the green tea. Some of the people here were commenting on the sort of evidence and sort of level 1, and perhaps also on doxycycline. Any thoughts?
So I've tried to get doxycycline, won't help. I tried to get diflunisal, can only order it out of the States, and it wasn't it's not passed here with the drug agencies. You can't order that, can't apply that. So we're basically left with tafamidis. Craig, I see, is asking about gene silencers with cardiac symptoms, because the studies haven't shown a benefit. They will be coming out. So inotersen, patisiran, we can use for neurological symptoms, so it's approved for that. Now these, I should note, these are expensive therapies. Tafamidis is $200,000 to $250,000 a year. This is not like evolocumab. So these are very, now our government, surprisingly, is covering it. So I got someone from the Ottawa Heart cardiologist said, well, how did you guys get it down there? And we can't order it in Ottawa. In fact, in Ontario, you have to do a biopsy, a heart biopsy, before you get approved for tafamidis. Here, if we have the symptoms and a positive PYP scan, they will approve tafamidis. So we have about, I think about 4 or 5 people now on tafamidis here now.
But between you and me, if that poor gentleman is Germany over 5 years, if you diagnosed at the early time point, you might have saved.
Right.
You might have saved that 200. I mean, I'm just being devil's advocate here.
Yeah.
Exactly. Going forward now, so when we see the red flags, how do you see? I mean, I see these patients when they're presented at TAVI rounds or multidisciplinary rounds because they're complicated, and we're like, oh, could this be? So, if you were to change practice, or the biggest thing you would ask referring docs to sort of think about?
Yeah, so I would be talking about if you see impressive LVH, or specifically if you have other disorders, back pain, or they come in with a walker and they got spinal stenosis, or they had a history of a bilateral carpal tunnel syndrome release. So those are the kind of patients I'd be saying, well, let's, and I see it here. I
Join the meeting.
Cardiologist, screening, doing a PYP scan. So they order it. So it's nice if it's negative, at least, you've ruled that out. So these aren't, and the blood work is no different than ordering cardiac markers. So if you see significantly elevated cardiac markers, that's another red flag that you might want to order PYP, and got to keep emphasizing, you don't want to miss amyloid due to myeloma, a light chain disease, because that's a tragedy. That there's definite treatment algorithm for this disorder, and if you diagnose it early, these patients can be get a good clinical result.
Yes, that's perfect. Any other questions from the audience?
Hi, Dave. It's Yemi. Thanks for the excellent presentation. My question has to do with the workup and what you do in your practice. So do you always do the blood work and the pyrophosphate scan when you see a patient you're suspecting this, or do you do one and then the other? How do you approach that?
So it's a good question. You saw that algorithms, if you have aortic stenosis, start with a PYP. I order both. So I do both, because the blood tests are relatively simple. Plus, I want to know what the BNP is and troponin, so I add on the triad. So we have, as I said, we have a stamp here now. We just stamp it on, so it makes it much easier for the heart function nurses. And then I order PYP.
And how's the
if you have a positive PYP, you could still have AL amyloid. So PYP scan can be positive in patients where the confusion rises, something called MUGUS, or monoclonal gammopathy of uncertain significance. So a lot of older patients have MUGUS. They have elevated free chains, and that's why it's important. That's why I get hematology involved early in this. Yeah.
Thanks.
Access to testing for the PYP, is that something or an issue?
Just check off the box. It's under nuclear medicine. It's under other. You just put PYP. That's it. Radiologists know it well now.
Beautiful.
Yeah, perfect.
Perfect. So with this, I will close, and thank you again, David, for a great overview. The comments were great here on the chat box, and thank you for providing that for us today. And we'll see you next week. Next week is going to be again on a little bit of variation of this, as David alluded to, looking at our trial and study that we're going to do here in St. John, trying to track better these patients and better understand them. Thank you.
Okay, thanks a lot.
Bye-bye.